Thanks everyone for joining in. This is Ryan with TAILOR MADE Compounding. Today we're going to try and tackle an interesting subject for the webinar. Frequently we have a lot of clinics.
This is how he sounds.
That,
this is live.
Sorry. Looks like we're having some issues with some audio real quick. I'll try and fix it before we move forward. Sorry about that, but as I was saying, we have a lot of clinics that do a lot of stem cells from, sort of umbilical origin, or we do adipose-derived autologous stem cells, or the bone marrow aspirate. And so whenever we talk about these things, we have a lot of peptides which can help with the differentiation and sort of lead to better clinical outcomes. So today we're going to focus on some of the literature behind essentially 5 of our products and how they might be used to help to have some better outcomes as it relates to all the procedures which everyone is already doing. And so with that, we'll start with just a quick overview of the cell differentiation pathway. Obviously, the mesogenic process starts with mesenchymal stem cells, which proliferate and then go under a commitment to certain subtypes. This includes osteogenesis, chondrogenesis, myogenesis, among others, right? And so this is just hopefully a good, graphic to sort of look at this differentiation process. The first one I want to talk about is the GHK-Cu. The GHK-Cu is one that is probably most well known for its cosmetic use. This was originally sort of isolated and discovered by Lauren Pickert in 1973, essentially, whenever it was purified from human plasma. What he found is that whenever he added whenever they added young blood to old liver cells, it tended to regenerate some of that tissue. And GHK was discovered to be at least partly because of that. And so with that being said, it's also found in the saliva and urine, and it's something that progressively declines as we age. We see that at age 20, the plasma level is about 200 nanograms per milliliter, and at age 60, it's less than half that. And so definitely something to take a look at. We also know that the decline in GHK coincides with a notable decline in rejuvenation capability. And so we know it has a lot of different effects, and I'm not going to go over these because I have done another GHK-Cu webinar. I really want to focus on its effect on stem cells. However, the GHK activates wound healing, it attracts immune cells, it's an antioxidant, anti-inflammatory, and it stimulates collagen and glycosaminoglycan synthesis in skin fibroblasts. All of these are really, really important for its effect on skin and along with skin elasticity and firmness. In particular, the statistics we always like to talk about are the 70% increase in collagen and a 36% decrease in wrinkles. This image over here talks about sort of the copper tissue repair and remodeling switch. In addition to its effect on skin and encouraging fibroblasts, it also has an anti-cancer effect. It's incredibly anti-inflammatory and has a lot of gene effects as well, affecting over 306 different genes and transcription of those genes. And so again, for a skin product and a cosmetic product, this is found just about everywhere and performs even better head-to-head than vitamin C and retinoic acid prescription concentration. In addition to its effect on skin, I've already talked about its effect on repair and recovery. This is talking about, in particular, a study about its effect to help heal ACL injury. This was done in a mouse study and showed significant effect in helping repair an ACL injury. One of the things found in this study was that, and here are some pictures, is that you actually had the best ACL repair effects with actually a lower concentration. Essentially, too much was actually too proliferative and caused essentially too much cellularity in these ligaments and tendons, which resulted in them being mechanically weaker. And so we know that a little bit is good, but too much can actually hurt this ligament tendon healing process. But this has been replicated. Its repair and recovery effects have been replicated again and again and again, even with wound healing, with diabetic wounds. For anything that is going to increase fibroblast synthesis, this is a good idea. So now we sort of want to look at how it affects stem cells. There are 3 really good studies about GHK and its effect on stem cells. This one in particular, the enhanced trophic factor secretion by mesenchymal and stromal stem cells with GHK. And here they basically treated cells in an in vitro manner and showed that they saw this is actually on a gel, and I won't go into it, but the gels are a huge point of emphasis as it relates to a lot of these stem cell processes. Peptide hydrogels used as a scaffolding for activation are really important. Again, I won't get into that today. It's a huge area of research and really exciting. But as we talk about this study, the real important thing was that whenever they complex GHK to these structures versus not complexing GHK to these structures, they saw significant increases in VEGF and therefore, angiogenesis. They also saw big increases in fibroblast growth factor compared to the unmodified gels. And so this data obviously shows that the pro-angiogenic potential of the mesenchymal stem cells can be significantly increased by the presentation of GHK and therefore should be considered whenever you're looking at tissue repair. So what we know and what the takeaway here is, if you're doing something that is trying to work with repair and recovery, GHK-Cu can really affect the effects of any type of stem cell treatment and really should be used in conjunction, even systemically, such as a subcutaneous injection with the product. And here we don't have to worry about too much because we saw a dose-dependent increase in the ability for stem cells to differentiate and that VEGF. The other study we see is that there's a stem cell recovery effect of copper. This is copper-free GHK, but the same has been seen with copper GHK, bound GHK. So we see that it promotes the survival of basal stem cells in the skin, which helps with wound healing and prevents scar formation. So this is just another point of emphasis to show that if you're doing something for repair and recovery and using a stem cell procedure, GHK can definitely help with that. In addition, it also shows that GHK in and of itself can help with activation of basal stem cells in any type of procedure. So if you're going a cosmetic procedure or even just going under surgery and want to prevent scar formation, this is another good consideration. And lastly, the other big one in this is that how GHK affects the DNA. As I talked about earlier, there are a lot of effects on the transcription and regulation of multiple genes with GHK. And one of the biggest takeaways here was that the GHK could increase the cellular stimulus and secretion of trophic factors by mesenchymal stem cells. Stimulus is sort of defined as combining the ability of a cell to perpetuate its lineage, as well as its ability to give rise to differentiated cells, interact with its environment to maintain quiescence, proliferation, and regeneration. So stimulus is what we want all of our stem cells to have, and by maintaining that and increasing cellular stimulus, we're basically giving our stem cells and the body a better opportunity to maintain homeostasis and do what it needs to do. So really, the GHK should be used in just about any stem cell procedure to make it more effective as it relates to recovery and healing, but also just with increasing cellular stimulus and the ability to regulate homeostasis. So really, GHK is almost a no-brainer for all these stem cell procedures. One of the other cool things about the GHK, and I talk about this study a lot, is that in a mouse study, even application to the thigh helped reduce wound healing time on the neck by over 50%. So what we know is that even topical applications have a systemic effect on wound healing. And so that's pretty cool, and it makes you think that even if you're not willing to do some of these subcutaneous injections with stem cell procedures, you can even do this as a topical, even on the face or on the thigh, and have that systemic effect, which would modulate its effect on all of these mesenchymal stem cells. The next one I want to talk to you about is the mechanogrowth factor. I borrowed some slides from IPS because Dr. Tees did such a good job on this. But mechanogrowth factor is essentially an IGF-1 splice variant. So what happens is whenever muscle is stretched overloaded, instead of sort of producing IGF, it produces IGF-1 EC, which is mechanogrowth factor. This is like IGF-1, anabolic. It works in a paracrine and autocrine fashion and increases stem cell pulls in muscle. And so what it does is it sort of increases that satellite stem cell reservoir, which allows muscle to recuperate. And so instead of just causing hypertrophy of muscle, we're also able to cause muscle hyperplasia by activating those stem cells to produce new myoblasts. And MGF expression is significantly increased, again, following any type of mechanical stretch, particularly, muscle stretch overload is typically what happens. So after weightlifting with those concentric muscle stress is definitely where it is highly upregulated. And it also has effects on the brain, heart, and bone, with this being highly upregulated as a way to heal after injury. And again, this goes into the skeletal muscle stretch overload, which results in an increase in the IGF-1 mRNA, which also increases the IGF-1 EC variant. In response to this, we know that MGF is vital to induce protein synthesis and activate those satellite cells. And this basically prevents, I should say satellite cells are activated to replicate by MGF peptide, and this is prevent from going any further until they fuse with muscle fibers and adopt a myogenic differentiation program. And so another cool thing about this is as we age, a lot of our satellite stem cells actually deplete in and of themselves, and it's one of the reasons that sarcopenia happens as we age. And so a lot of people have sort of postulated that using PEG-MGF or the long-acting version of MGF, which is pegylated, basically has a polyethylene glycol attached to it, might be a way to help with sarcopenia as you age, but it also might be able to keep those stem cells alive and proliferating. And the effect on stem cells alone via MGF and sort of maintaining that reservoir of muscle stem cells and satellite stem cells is extremely positive, but it has effects even beyond that. What we know is that mechanical growth factor regulates migration and differentiation of bone marrow mesenchymal stem cells. And so one of the really cool things about this is this particular study showed that the PEG-MGF or the MGF peptide produced a significant increase in the migration ability of stem cells. And it did this via a mechanism which you'll find throughout stem cell activation, which is the ERK1/2 signal pathway, which again promotes cell migration. And so the idea here is that the migration effect of MGF via these bone marrow mesenchymal stem cells is used for homing to certain tissue. For instance, if you were to have a heart attack or a TBI, you would increase the expression of the IGF-1 EC or MGF, and that would recruit mesenchymal stem cells to participate in repair and recovery. So the functional idea here is you might be able to inject MGF, particularly into areas where you want to treat with these stem cells in a systemic fashion for greater added benefit, where it would recruit and differentiate these stem cells, particularly if you're doing any type of BMAC procedure. So for the MGF, really the one big takeaway is think about injecting it locally to the site of damage you'd like to heal before doing a stem cell procedure. And again, we do that with the PEG-MGF, the long-acting version, because the MGF is degraded rapidly. One that is really, really exciting is the thymosin beta-4. The thymosin beta-4 is one that most of you are probably familiar with. It was originally discovered as part of the thymus fraction 5 in Dr. Goldstein's laboratory in New York. It's a 43 amino acid product present in all cells and is one of the first peptides that is naturally upregulated in areas of damage, particularly in wound beds. It's got a sort of a bad name in sport and is WADA prohibited because a lot of athletes use this to prevent any delayed onset muscle soreness, and it is definitely well known. One of the main ways that thymosin beta has its effect is through its actin monomer sequestering protein. So it essentially helps build that cytoskeleton in order to enhance wound healing. In addition to building that cytoskeleton, it also has a pretty big effect on angiogenesis, cell migration, and then it also promotes stem cell differentiation. And we're going to talk a little bit about that. It is FDA approved for sort of an obscure eye disease, but it has great effects on stem cells in addition to all of its other effects for wound healing. This is a product that combined with BPC often that is used as a repair product for just about anything, TBI, stroke, any type of acute or chronic injury. It's also been helpful for. And this goes into a little bit of some of its cellular pathways and some of its ways that it can prevent oxidative stress and keep cells alive. Here I mentioned its ability to promote mesenchymal stem cell proliferation and increase cellular levels of ATP. But I really want to talk about its effect on stem cells. This is a study I mentioned earlier, and this study shows that it's able to promote the expansion of human adipose stem cells via an ILA-dependent mechanism. And again, this is using the ERK pathway again, and it's really to be considered as a pretty ubiquitous tool for mesenchymal stem cell expansion in cell therapeutics. To go sort of above and beyond this, we have seen time and time again that this can help in a variety of cellular procedures, whether it is, just via those monocytes and PRP procedures for hair. We know that this holds a lot of promise. And the reason is mesenchymal stem cells, are limited in number. You have to limit them in number that you can obtain from each donor site. And it's important to establish standard methods for that mesenchymal stem cell expansion using a lot of tropic factors. And thymosin beta-4 seems to be the best for this. This is also its ability to differentiate these adipose-derived stem cells is dependent on concentration. So the more thymosin beta-4, the more differentiation you would have. Beyond that, it also leads to a considerable increase in a protein called MCP1, which also promotes adipose stem cell derived differentiation, and it also promotes the proliferation and migration of these bone marrow mesenchymal stem cells. And so we know that this is affecting adipose and bone marrow, and great for both of those procedures, and is sort of ubiquitous in its ability to proliferate and increase the effect of these stem cells. So this one should be considered for any type of autologous procedure where you're harvesting tissue to inject back in. Beyond that, there's another great study which shows that thymosin beta-4 is able to direct cell fate determination of human mesenchymal stem cells through biophysical effects. And so basically this is saying that due to its actin sequestering protein, the actual physical environment that these stem cells are sensing can actually determine their fate and lineage development. And this study actually shows us one of the very first things to be concerned about when thinking about adding TB4 or any peptide to stem cells. And that is that what they saw in this particular study was that thymosin beta-4 was actually able to induce the more adipogenic differentiation rather than osteogenic. And so this actually, in some models, could even prevent stem cells from going to sort of help in an osteoporosis manner. So if you're trying to heal bone with some of these stem cell procedures, this is the first time we would say do not use thymosin beta-4, because a lot of times it will shift differentiation away from that type of differentiation. The last one is sort of the neuroprotective and neurorestorative effects of the thymosin beta-4. Here there are a lot of mechanisms for this, and a lot of really, really interesting mechanisms. But thymosin beta-4 has been studied in stroke and a lot of TBI because it's able to promote neurogenesis, and beyond that, it's able to induce differentiation and survival of rat brain progenitor cells. And so this is a really, really cool mechanism. And the reason I think it's so fascinating is because it involves a lot of the other mechanisms we talk about with some of our peptides, like the PNC27. Through its activation of this active PI3K and increased AKT, we get increased MDM2, which then binds to P53 and prevents apoptosis. So we're able to keep a lot of these cells alive. And just like sort of the opposite reason you would want to keep them alive with the PNC27, where we're trying to kill those cancer cells, these increased MDM2 and therefore deactivated P53 leads to the prevention of apoptosis, which is exactly what we want in some of these traumatic brain injury cases or stroke. And so the other consideration here is if you're using stem cells for any type of procedure to help with survival of neurons or any type of brain damage, this is definitely one to add to the procedure. Just to go to sort of general dosing, I didn't do this with the GHK because what we know with the GHK is that it is not as dose dependent, and really any bit of GHK will help improve the outcome with the stem cells. I also didn't go over the PEG-MGF, but usually that's done at around 600 micrograms to 1 milligram in addition to a procedure. The thymosin beta-4 we typically do in short courses. A lot of people worry that it can be proliferative for different types of neoplasias, and there's a lot of data to suggest that. There's also a lot of data to suggest that it has very, very different effects on different types of cells. But with this, the TB4 dose is usually around 750 micrograms daily subcutaneously, and we recommend usually not more than 2 months. It can be used with other healing peptides. Things like the BPC are pretty frequent. The GHK is absolutely allowable and will not have any contraindications, but also dose may vary. You know, in relatively acute settings like TBI or stroke, higher doses are used. In some of the clinical trials, they've even used up to 1.2 grams IV. So you can't really go wrong with dosing here. And if you're going to optimize a stem cell procedure, you might want to consider even higher doses, such as 1 to 2 milligrams. One of the really exciting products we have out now is called the 5-amino-1-MQ. I've talked about this in my Senescence webinar, so I'm not going to go through it a ton, but one of the things we've seen is that as we age, we increase levels of an enzyme called NNMT. NNMT is found in the cytosol, and it basically takes the nicotinamide and converts it to the 1-methyl-nicotinamide. This basically takes a lot of reagents out of that NAD salvage pathway, and if we block it, what we can do is increase nicotinamide, which increases NMN, and therefore changes the intracellular levels of NAD+. This is important because a lot of theories of aging have sort of postulated that whenever SIRT1 loses its effect, we're unable to deacetylate a lot of things that would produce longevity type of effects. You know, for instance, P53 being acetylated prevents its use, and so whenever SIRT1 is activated, it would deacetylate P53 and cause some cellular apoptosis. And so this has a lot of implications. The main implications that most people see with this are the effects of increased energy metabolism and decreased white adipose tissue mass. What we know is that the 1-MNA, or the 1-methyl-nicotinamide, is highly correlated with white adipose tissue, body mass index, and waist circumference. And so a lot of people see this as just a weight loss product, but it's definitely a lot more than that. Also, I should say that mice who were treated with this showed that despite what they ate, they were protected from obesity. So even with high-fat diets, they were unable to gain weight. To add to sort of the weight loss story, this is the mouse trial, which was only 11 days, and showed in this mouse trial they lost over 10% of their body weight, with over 85% of that being in the white adipose tissue. And so this is obviously extremely exciting and definitely has some body composition type of considerations. But I also want to talk about its weight loss, beyond its weight loss effect, its effect on muscle stem cells. This study shows that it can basically, by blocking NNMT in muscle stem cells as well, you can actually increase this NAD-dependent SIRT1 activation, which can basically flip a switch and cause these muscle stem cells to be activated and prevent the senescence there. So we can actually increase the pool of muscle fibers, we can increase the pool of muscle stem cells and let them do its job in injury. You know, this is a really, really exciting thing because, you know, as we age, we get a progressive decline in muscle mass and strength and impaired regenerative capacity, and a lot of that is due to these muscle stem cells becoming senescent and not active. So we can do things like PEG-MGF to activate these and increase the reservoir of these muscle stem cells, but they still might be senescent. And so using a 1-2 combination like this can be really, really effective. Just as some of the key takeaways there, what we were able to do whenever mice were treated with this 5-amino-1-MQ, they were actually able to increase the cross-sectional area of the muscle after injury by almost double. Beyond that, they were able to increase contractile force by around 70%. And so this is definitely one that can be used even as a standalone outside of your stem cell procedures to basically activate SIRT1 and really keep these stem cells functioning exactly how they should be, and also to increase their number. So this can also be paired with PEG-MGF to really target muscle injury and muscle stem cells, and also increase that contractile force. So in addition to the weight loss effects, in addition to the longevity effects, in addition to some increased anabolic processes as a result of polyamine flux, we also see it has a direct link to stem cells. Another anecdotal thing I want to talk about here before we go on is that a lot of times whenever you harvest adipose-derived stem cells or the bone marrow aspirate from older individuals, you actually have a lot of stem cells which are in the senescent state or have senescent depletion. And as a result, there have been many studies that document that if you have a highly senolytic, a high senescent load in these individuals, you can actually inject, these cells into the knee and make osteoarthritis worse. And so doing some type of treatment with some of the senolytic therapies, what we talked about in previous webinars, like the rapamycin, like the 5-10 quercetin dasatinib, and the FOXO4 DRI, are also good additives to think about when you're thinking about stem cell therapy procedures. And maybe even doing 2 or 3 weeks prior to procedures would be an effective treatment strategy to make sure that you're not including senescent cells in your treatment strategy and hurting the potential that it could have to do good. Lastly, not least, I'll talk about the growth hormone-releasing hormones and their effect on tissue. Just as a general review, we target, a lot of people have used CJC and ipamorelin, tesamorelin, sermorelin, GHRP2 and 6, or the ibutamorelin or MK677. These are all working on pituitary receptors to increase growth hormone release, but they're actually found in cells all over the body, and stem cells are definitely included in that. I have a couple studies here, 4 in particular, which show its effect on different types of cells. This in particular looks at Sertoli cells and how growth hormone can have an effect. And basically growth hormone and a precursor molecule of growth hormone-releasing hormone can activate the expression of stem cell factor, which is important for myeloid and erythroid hemopoietic progenitor cells. And so even here we're seeing that growth hormone-releasing hormones, such as one like the tesamorelin, the CJC, or the sermorelin, can have an effect which increases stem cell effect and increases these progenitor cells. Beyond that, and also in a really cool way, we also see the growth hormone-releasing hormone is produced by adipocytes and regulates lipolysis. And so here at the bottom, I've highlighted a section from the conclusion of this paper, which shows that growth hormone-releasing hormone at low doses may exert an anti-obesity effect by inhibiting mesenchymal stem cell differentiation into adipocytes and by increasing adipocyte lipolysis in the autocrine and paracrine pathway. So we already know that these things are great to affect the pathophysiology of obesity, but this shows a direct mechanism by which it can affect stem cells within your own body to stop differentiation into adipocytes and increase the lipolytic effect that your body naturally produces. In addition to this, this study talks about growth hormone-releasing hormone and how it can increase cell survival and anti-apoptotic effects of bone marrow by activating a particular pathway. And so here we know that growth hormone-releasing hormone has already been confirmed to exist on cardiomyocytes and mesenchymal stem cells, and that the effectiveness of these mesenchymal stem cell transplantations can be restricted by survival rate. And so basically this study was looking at, if we treat with a growth hormone-releasing hormone, are we able to increase that survival rate of these mesenchymal stem cells? And what we saw was a significant improvement. There are a lot of basically the conclusion was that the agonist of the growth hormone-releasing hormone can activate the receptor of mesenchymal stem cells to enhance its viability via the STAT3 signaling pathway and promotes angiogenesis of ischemic hind limb of mice. So what we're seeing already on 3 of these growth hormone-releasing hormone studies in stem cells is that it can promote proliferation and particularly of things like cell survival and angiogenesis. And that means that growth hormone-releasing hormones like CJC, sermorelin, and tesamorelin should be considered in a lot of those procedures. This, again, just goes a little bit further on that, talking about the cardiac system and its effects on mesenchymal stem cells. And again, the takeaway here is these findings confirm for the first time the expression of growth hormone-releasing hormone receptor in both of these stem cell types, and it can promote the proliferation and enhance survival of these cells. And so the key takeaway for this one is that all mesenchymal stem cells or any stem cells have growth hormone-releasing hormone receptors, and almost always stimulation of these receptors leads to proliferation, activation of the cell, which leads to better functional recovery, especially in angiogenesis and cell survival. And then also in addition to that, it prevents adipocyte differentiation and causes lipolysis. So a lot of good effects in the muscle. So with all that being said, this is hopefully the key takeaway. 5 things we learned, which is that we know that GHK can aid stem cell procedures where wound healing is needed and an increase in blood flow is needed. So think of these for any of your stem cell procedures, or even if you just want to optimize the stem cells already endogenously produced in the body. Particularly the other thing with the MGF is that PEG-MGF can be used in a local administration fashion to help attract stem cells to an area via some of that migration effects, but it also can help replenish satellite stem cells in muscle tissue. When we think about the thymosin beta-4, we know it promotes proliferation of these adipose stem cells and the bone marrow stem cells in a dose-dependent manner, but may actually be hurtful for osteogenic differentiation. So don't use it when you're trying to heal bone. We also know that senolytic senescent stem cells can actually be harmful. So think about senolytic options such as the rapamycin, fisetin, before doing a stem cell procedure where you're sort of taking autologous stem cells. But beyond that, if you'd like to use the 5-amino-1-MQ, you can help restore some of that muscle stem cell homeostasis and upregulate some of that its sirtuin activity, and as a result, upregulate the effect that it has on repairing muscle. And then lastly but not least, growth hormone-releasing hormone receptors are found on almost all stem cell tissues and seem to lead to a proliferation and activation of the cell, which leads to better functional recovery. So here we sort of talk, you have essentially 4 different peptide mechanisms, 1 small molecule mechanism in the 5-amino-1-MQ, and then you have a lot of other mechanisms with the senolytic products to use as pre-treatment whenever you're harvesting any of these autologous stem cells. So I hope that this sort of helps ground you. What I'll do as a follow-up is provide a lot of information and all the papers that I referenced here in addition to this presentation. And so before I move on, I'd love to take any questions and see if I might be able to talk a little bit more about any dosing protocols. I'm not seeing any questions pop up. So if anyone has
I have a
question.
Oh,
absolutely.
So far you've been talking about stem cells, primarily in terms of doing wound and tissue recovery with using stem cells. How about using a patient post-surgically, post-operatively? Which peptide would you consider using, and or would you use a combination of peptide?
Yeah, no, I think that in all of our perioperative surgeries, there are a lot of considerations. Some of the most frequent considerations revolve around the thymosin beta-4 and BPC. Both of those are frequently used after surgery just due to their pleiotropic effects on healing regardless. And those effects on healing are going to actually be direct, not necessarily through its activation or effect on stem cells. But the BPC, thymosin beta-4 are definitely ones to consider. If you want to worry about scar formation, the GHK is also one you would want to think about. Both applying topically and as a systemic, you can reduce some of that scar formation. I think that those generally sort of are the ones that are most often considered, but the growth hormone-releasing hormones are not to be discounted either, as they have, as everyone knows, growth hormone has an incredible repair and recovery effect, and those are also extremely useful. So usually there, people will go things that they really bump up the IGF-1, for instance, like the tesamorelin.
Now, how about severe issues with keloid formation? Are any of these peptides, if you apply these for wound healing, would it accentuate or make keloids worse, or would it improve actually keloids?
Yeah, so unfortunately, the keloid data has not been studied directly with any of these. However, just through anecdotal experience over the past couple of years, we have had patients who have experimented with the GHK who are very, very prone to keloids and have reported that they don't respond, they don't keloid like they had previously when we have topical application of the GHK. I can also say, though, that usually the GHK, for those people who also keloid, is usually combined with a topical BPC. The BPC has several studies in wound healing. Particularly, there's one really, really good one after laser resurface injuring or CO2 lasers. And so we do that as a combination, and that's typically what's been used in these more anecdotal settings. Perfect. Well, like I said, I don't see any more questions. So if anyone has any more questions, they're more than welcome to contact me directly at rs@tailormadecompounding.com. We'll post this recording as well as the slides and the clinical research as a follow-up. And I look forward to answering any questions someone might have. Thanks so much.